Hello, everyone. I'm Dr. Rodgir Cohen, and today we're exploring a critical but often overlooked distinction in healthcare psychology: the difference between moral trauma and PTSD. While both can profoundly affect healthcare workers, understanding their unique characteristics is essential for proper recognition, treatment, and prevention. This raises a key question: why do some healthcare providers experience lasting psychological harm not from what they witnessed, but from what they were forced to do or prevented from doing? Understanding PTSD: fear based, threat oriented. Let's begin with PTSD. Post traumatic stress disorder is a well recognized psychiatric condition that develops following exposure to actual or threatened death, serious injury, or sexual violence. The core characteristics of PTSD center around fear. It's a fear based response where the trauma centers on threats to personal safety or witnessing threats to others. PTSD is fundamentally threat oriented. The psychological injury stems from perceived danger. The symptoms we see in PTSD, hypervigilance, avoidance, and re experiencing, are actually adaptive survival mechanisms that have gone awry. The brain is trying to protect the person from future threats, but this protection becomes dysfunctional. For example, consider an emergency room nurse who develops PTSD after being physically assaulted by a patient. She experiences flashbacks and intense fear when approaching similar patients, even though she knows intellectually that most patients pose no threat. Her brain's threat detection system is working overtime. Understanding moral trauma: value based, conscience oriented. Now, let's contrast this with moral trauma, also called moral injury. Moral trauma occurs when individuals perpetrate, witness, or fail to prevent actions that transgress their deeply held moral beliefs and expectations. Unlike PTSD, moral trauma is fundamentally value based. The injury doesn't stem from physical threat, but from violations of core ethical principles. It's conscience oriented, centering on guilt, shame, and loss of moral integrity. What makes moral trauma particularly devastating is that it disrupts one's identity. It challenges the person's self concept as a good or moral person. The question isn't, am I safe, but am I good? Can I still call myself a healer? Consider this example: a physician forced to ration critical care during a pandemic, making triage decisions that resulted in preventable deaths. Even though she followed proper protocols, even though any reasonable person would acknowledge she had no choice, she experiences profound guilt. She can't shake the feeling that she violated her oath to do no harm. This is moral trauma. Key differences. A direct comparison. Let me highlight the key differences more directly. In terms of primary emotions, PTSD involves fear and terror, while moral trauma involves guilt, shame, and betrayal. The core concern is different. PTSD asks, am I safe? While moral trauma asks, am I good? The triggers differ too. PTSD is triggered by threats to physical integrity, while moral trauma is triggered by violations of moral or ethical standards. Cognitively, PTSD focuses on danger assessment, constantly scanning for threats. Moral trauma focuses on self judgment and meaning making, trying to reconcile one's actions with one's values. The typical symptoms differ as well. PTSD presents with hypervigilance, flashbacks, and avoidance of triggers. Moral trauma presents with self condemnation, loss of trust in oneself and institutions, and often a spiritual or existential crisis. Why healthcare workers are uniquely vulnerable. Healthcare settings create unique conditions where both PTSD and moral trauma frequently occur. Let me explain why healthcare workers are particularly vulnerable. There are structural factors at play: resource constraints, insufficient staff, beds, or equipment, force impossible choices. Administrative pressures create conflicting demands between patient care and institutional efficiency. Legal and regulatory constraints sometimes create policies that conflict with professional judgment. Healthcare workers face moral stressors that are uncommon in most other professions. They make end of life care decisions that feel inconsistent with patient dignity. They're sometimes required to follow orders they perceive as harmful or futile. They witness substandard care due to systemic failures beyond their control. Perhaps most painfully, they're unable to provide the level of care they were trained to deliver and that they believe their patients deserve. These aren't just bad days at work. These are experiences that strike at the core of why many people entered healthcare in the first place: to help, to heal, to reduce suffering, overlap, and comorbidity in healthcare populations. Now we need to address the complex reality that PTSD and moral trauma frequently co occur in healthcare workers, particularly after crisis events like the COVID-19 pandemic. There are several areas of overlap. Both conditions can lead to avoidance behaviors, avoiding certain work situations or patient types. Both involve intrusive thoughts, though the content differs. In PTSD, these are flashbacks to the threatening event. In moral trauma, it's rumination about moral failure. Both can cause emotional numbing, detachment, and reduced emotional responsiveness, and both commonly disrupt sleep. Here's the critical point: a single traumatic event can trigger both conditions simultaneously. Imagine a nurse who is assaulted while trying to prevent a patient from committing suicide. She might develop PTSD from the assault, the physical threat, the fear, the hypervigilance, but she might also develop moral trauma from feeling she failed in her duty of care, that she should have been able to prevent the death. This comorbidity makes recognition and treatment more complex, but also more urgent. Why the distinction matters clinically. So, why does this distinction matter so much? Because treatment approaches differ significantly. For PTSD, we use trauma focused cognitive behavioral therapy, exposure therapy to reduce fear responses, and medications targeting anxiety and hyperarousal. These interventions are evidence based and often effective for PTSD. But for moral trauma, we need different approaches. Treatment focuses on meaning making and narrative reconstruction, helping the person create a coherent story that integrates the traumatic event. We engage in self compassion and forgiveness work, which may feel counterintuitive but is essential. We address spiritual and existential dimensions because moral trauma often involves questions of meaning and purpose. And crucially, we work on systemic advocacy and empowerment, helping the person channel their experience into positive change. Here's the danger: treating moral trauma solely with PTSD interventions may miss the core injury. Exposure therapy won't help someone whose wound is about violated values, not fear. We might even cause harm by focusing on the wrong dimension of the person's suffering: organizational and systemic responses. This brings me to perhaps the most important point of this entire lecture. Because moral trauma often stems from systemic and organizational factors, effective response requires institutional change, not just individual treatment. Healthcare organizations need to implement ethics rounds and structured debriefing, opportunities to process morally distressing events as a team. They need to review and revise policies that create moral distress in the first place. They must create empowerment structures that give frontline workers a voice in decisions affecting patient care. Adequate resourcing is not a luxury, it's an ethical imperative. When we fail to ensure staff have what they need to provide ethical care, we create the conditions for moral trauma, and we must create psychological safety, cultures where workers can voice moral concerns without fear of retaliation. Remember this: you cannot counsel individuals out of organizational problems. If the system is forcing healthcare workers to violate their values, individual therapy is just a band-aid. Moral trauma prevention requires systemic solutions. Conclusion: toward better recognition and care. Let me conclude by emphasizing why understanding the distinction between moral trauma and PTSD is essential for anyone working in or supporting healthcare systems. Here are the key takeaways. PTSD is fear based and threat oriented. Moral trauma is value based and conscience oriented. Both can and do co occur, particularly in healthcare settings. Recognition requires understanding the unique phenomenology of each condition, what it feels like from the inside. Treatment approaches must be tailored to the specific type of injury, and organizational and systemic changes are crucial for preventing moral trauma in the first place. As we continue to support healthcare workers through increasingly challenging circumstances, this understanding becomes not just academic, but a moral imperative. The well being of our healthcare workers depends on our collective commitment to recognizing and addressing all forms of psychological injury they face, not just the ones we've traditionally understood, but also these profound wounds to conscience and moral identity. Thank you for your attention.